Good afternoon, dear colleagues. I want to report about my research within the last 30 years to find new approaches to diagnosis and therapy of diseases in childhood and adolescence. Uh, Probably my most important research project was the introduction of beta blocker therapy to treat pediatric heart failure due to congenital heart disease, starting in 1995 with the first beta blocker therapy in an 8-year-old girl with effusions after Fontan operation, and the effusion disappeared within 3 days. 1 year later, I introduced propranolol in the therapy of severe heart failure in an infant with single ventricle after pulmonary banding, and the infant improved in 1 week, and that is the reason for the next publications in 1998 with the first 8 infants with severe heart failure and the prospective randomized beta blocker trial in infants with severe heart failure due to congenital heart disease, published in 2000 with a significant improvement of the clinic and neurohormonal activation in propranolol-treated infants. There's one case with propranolol therapy in an infant with multiple liver hemangioma and heart failure treated in 2003, 5 years before the important publication of the Bordeaux group, who introduced this therapy in pediatrics. In 2007, we published the first prospective randomized beta blocker trial after surgery of congenital heart disease in older children and young adults. Looking to the publications on PubMed, we have the first positive report from Finn Wagstein in 1975 with a long battle about the therapy with the first guideline recommendation in 2000 becoming the most successful pharmacotherapy of heart failure in adults. Some years earlier, I published my results in children, but unfortunately, my colleagues didn't recognize the benefit of the therapy, and we have only some publications in the next years, most of myself. Looking for the reason that this pharmacotherapy is not very popular in pediatric cardiology, we have to remind to the history and the success story of congenital heart surgery starting in 1940. Only 20% survive the important heart defects, and by introducing these operations, we improve prognosis to 85% in 2000. And my colleagues believe that we can only improve heart failure in patients with congenital heart defects by operation or interventions. And my intention was to improve the condition of the infants before surgery. Why it is so important also today, where we're standing today. There are more than 3 million of congenital heart defects children worldwide in 2019, and nearly 200,000 of these children die from congenital heart defects. Most of these children who die are infants, around about 50%, and most of the infants die from heart failure. Around 80,000 infants die from heart failure worldwide. And my special understanding of heart failure was that I measure and realize the impact of early life stress in infants with heart failure. There are some heart failure, there are some early life stress models from hunger in the third world, from infants with congenital heart defects, and from premature infants. And my idea was to measure early life stress in my infants who suffer from heart failure, and I found very high norepinephrine levels in patients with univentricular hearts and in patients with Down syndrome and congenital heart defects. These norepinephrine levels was much higher as in preterm infants, also those who died. We introduce heart rate variability measurements in Holter ECG in this time, and we found very low valgus activities in our children with heart failure due to univentricular hearts and Down syndrome and congenital heart disease, comparable to premature infants with cerebral palsy. After the publication of my results, the pediatric cardiologist stands at a therapeutic crossway. Should they further use digoxin ACE inhibitors and catecholamines to treat heart failure in infants with heart failure, knowing that they have no positive effect on the clinical heart failure score and they further escalate neurohumoral activation, most of all, a higher plasmarenin activity? Or should they de-escalate the neurohumoral activation by using the beta blocker propranolol, showing a significant lower ROS score, measuring heart failure, and significant better neurohumoral activation, and most of all, significant better heart rate variability? Today we know this is the most important predictor of mortality in this group. However, the cardiologists decide to use further ACE inhibitors and diuretics, and now we see trend of mortality in patients with congenital heart defects in Germany with higher mortality starting in 2010, and I think it's the time to rethink about the therapeutic approaches used today to treat patients with congenital heart disease. This is so important if current epigenetic model suggests a complex early childhood imprinting process in the first 1,000 days of life. This is the time where my patients suffer from severe heart failure due to congenital heart disease. The most often used models are those with intrauterine growth delay or stunting in the third world. Other models think about prematurity and inflammation, social deprivation and neglect. And all these early life stress models explain short stature in later life and a worse cognition called attention deficit hyperactivity disorder. At the end of the story, there is an increased cardiovascular risk due to hypertension or metabolic syndrome. And I introduced in 2015 the concept of autonomic imprinting that explains the complete course of early life stress on later disease. And this concept has very important therapeutic consequences if the system have a high plasticity in the first 1,000 days of life, and I can improve the course, but in later life the disease are very stable and cannot improve by therapeutic approaches. And indeed, we could show that beta blocker therapy of early life stress due to heart failure is treatable with propranolol in early infancy. And these infants have a high improvement of vagus activity in green for improvement of more than 80%. Compared to other infants without heart failure who have hemangioma, who have normal vagus activities that do not improve with the therapy. And most of all, um, grown up with congenital heart disease who are treated with bisoprolol in later life cannot improve by beta blocker therapy compared to the infants. Looking on physical performance of patients with congenital heart disease, we have a great impact of age on the left side with an decrease of maximal oxygen uptake in spiroergometry in patients with operated congenital heart disease compared to healthy control. And this is related to a lower vagus activity in heart rate variability measurements indicated by lower RMSSD values and high frequency power values in fast Fourier analyzers. Like our colleagues in Munich, we early measured maximal oxygen uptake in our patient with congenital heart disease in Göttingen, and we found a lower oxygen uptake and a lower vagus activity measured by the RMSSD value in our patients. The colleagues from Munich recently show that the decrease of RMSD is most of all at night time, and the ratio from night to day RMSD value is lower in patients with congenital heart disease. We measured these values in younger children around about 12 years who had better maximal oxygen uptake, but we see significant better RMSSD values in those children who have severe heart failure in infancy treated with propranolol. And we unfortunately don't have the spiroergometry data of these children who are young today, but probably they have a better physical performance. However, we have the RMSSD data of our children treated with propranolol in early infancy, and we see the early improvement of RMSSD after beta blocker therapy, and there are nearly normal values up to the 13 years of life. Early in 2007, we recognized that chronotropic incompetence is the reason of a bad physical performance in patients with congenital heart disease. That is confirmed by many other groups. Compared to healthy hearts, there is who have a low physical performance due to dysautonomia or due obesity, they don't have chronotropic incompetence compared to those patients with congenital heart disease. Furthermore, we could show a better an improvement of height in children with heart failure and Down syndrome treated with propranolol in early infancy due to severe heart failure. In this children, we have a normal height up to the 120 month of life compared to this patient with Down syndrome and heart failure who are treated with standard therapy in red. Again, compared with healthy heart Down syndrome patients, our patients have over average height growth within 11 years of life. In 2020, I realized that this autonomia is one of the most important features in COVID-19 patients, in the acute course, but also in long COVID patient. And I've published my own case in 2020 with a Holter ECG registration over more than 7 days, and the first description of a dysautonomia in a child with long COVID, with long COVID, and the first post-oral orthostatic tachycardia syndrome published in Monatschrift für Kinderheilkunde. Furthermore, I published the first description of autoantibody against adrenergic muscarinic receptors after COVID-19 and BioNTech vaccination in children, and I published my successful therapeutic approach in children with long COVID in 2023. And again, there are many papers about dysautonomia after COVID-19 in adults in gray, but again, the pediatricians don't realize this problem. Looking to our Holter ECG data, we realize where are the children who have dysautonomia. These are the children with heart failure due to congenital heart disease, but again, there are children with obesity, attention deficit disorder, growth failure, and most of all, the somatoform disorders after infections. What about the vagus activity in the human life cycle? We have very low vagus activities after birth, and the increase of vagus activity within the first 1,000 days of life. Further increases occur in puberty, and after that time, the vagus activity decreased to very low values in adulthood. And there are patients with normal vagus activities during their life, and those with very low vagus activities in red, and those with high vagus activities in green. What are these patients? These are the premature infants, these are the infants with congenital heart disease, these are the patients with growth failure, and those with attention deficit hyperactivity disorders. And all this has an impact on cardiovascular prognosis. But there are other group in this illustration who have normal vagus activity at birth, but have a decrease after an inflammation or after other diseases, who have low vagus activity due to this disease. This can occur in infancy, childhood, and also in adults. Today, there are many children and adolescents who suffer from dysautonomia, who visit our practice with chronic fatigue, dizziness, and many symptoms that have a high impact on quality of life. We perform some physical examination, some laboratory values, but we cannot find the reason for this problem. And if we could not find a reason, we sent it to the psychiatrist, who also found no reason for this disease, and the patient is very disappointed if nobody could help him. I realized very early during the pandemic that the patient have a problem with dysautonomia, and I published the first patient with post-oral orthostatic tachycardia syndrome after COVID-19 and the Monatschrift für Kinderheilkunde in 2020. After the lockdowns, the problems increase in patients after COVID-19, but also in patients after vaccination. And I found an objective problem in these patients who have a significant higher heart rate increase while standing after COVID-19, but also after vaccination. And indeed, the epidemiologic data show a significant increase of the diagnosis of post-oral orthostatic tachycardia syndrome after the COVID-19 pandemic. This is my therapeutic approach to dysautonomia. In this patient, first of all, there are some lifestyle recommendations like more drinking, more table salt, contrast shoulders, to get normal body weight, to spurts in those who are able to make spurts and compression garments. I recommend nutritional supplements with 2 grams omega-3 fatty acids in all patients. If this lifestyle recommendation do not improve the symptoms, I recommend low dose propranolol 10-10 0, or if this is not better after the therapy, I recommend ivabradine 5-5-0. Those with high symptom burden get amiodarone drops if they have these problems, but this is not a causal therapy that improves the symptoms. And the most severe symptoms are treated with saline infusions. I published my results in 2023 with a significant better heart rate control in those with inappropriate sinus tachycardia and post-oral orthostatic tachycardia syndrome. All these heart rate measurements are highly significant after omega-3 fatty acids, after low-dose propranolol, and after ivabradine in all these patients with dysautonomia. These are my Holter ECG data and the spiroergometry data from literature showing an improvement of heart rate variability, most of all after ivabradine and yellow. The heart rate variability becomes better, the heart rates are lower, and the maximal oxygen uptakes improve after all these new therapeutic approaches. Looking to my publication and citations within the last 30 years, I have some publication during my university career, and after that I'm the head of the Caritas Hospital in Bad Mergentheim, and I further have a publication with an increasing number of citations, most of all after the COVID-19 pandemic. I have in private practice the most citations in my life. I wrote about this 30 years of therapy of autonomic disorders in children, and in this book you can find all my data and the citations from myself and other who are busy in this part of research. This is a foreword in this German book in English. The autonomic nervous system is the operating system of our body. Understanding it better is the key to a better understanding of our body and soul and a quantum leap for medicine. I thank for your attention.